process. And it has a very high mortality rate in the pre-antibiotic era. Right? So if you see this diagram, you look at this tooth, any odontogenic infection has a potential to progress to form osteomyelitis if not treated properly, right? So here you may have a periapical abscess which will cause inflammation in the medullary cavity in the bone marrow area, which will lead to the formation of pus, and then this pus will travel through all the Haversian system, and then it will perforate it through the cortex and will be collected underneath the periosteum. Right. Osteomyelitis commonly occur in mandible. So it's more common in mandible compared to the maxilla. Why? Because of the density of the bone. The maxilla has a lot of cancellous bone compared to the mandible. Mandible is denser, so you have more cortex compared to cancellous bone. The other thing you have to remember that maxilla has a lot of blood supply. So it has a lot of major blood supply from other sources. When mandible is only relying on a single arterial blood supply, which is the inferior alveolar artery. So any problem with the inferior alveolar canal or the mandibular canal, any obstruction in the inferior alveolar artery will cause inflammation of the marrow, and then it will lead to the formation of osteomyelitis. In comparison, on the maxilla, you have so many blood supply. You have posterior superior alveolar artery, you have middle and anterior superior, you have infraorbital artery that can supply the area, you can also have spinopalatine artery that can also supply the area. So if one vessel is affected, the other vessel will contribute to the lacking of the blood supply. Right? So that is the difference between mandible and maxilla. So mandible is more commonly affected. Why? Because of the type of blood supply. Secondly, because of the density of the bone. Okay, when you look at the compact bone or the cortex, comparing the cancellous bone, the cortex, you will have, you don't see trabecular in the cortex. So what you will see, dense bone with the Haversian canal or the Haversian system. In this Haversian system, you have feeding vessel, you have blood vessels. If you look at the cancellous bone, you have trabeculae. So between these trabeculae, you have a lot of blood vessel running in between. So you can see the difference in terms of blood supply between compact bone and cancellous bone. From here, you can see if there is any pathological event of osteomyelitis, compact bone will be affected severely compared to cancellous bone. So what is the etiology of osteomyelitis? Right. The most common etiological factor is odontogenic infection, meaning infection from the tooth and also the tooth supporting structure. Right. Second etiological factor is trauma. If a patient have a fractured maxilla, which involving the alveolar ridge, which involving the palatal bone, usually there will be a breakdown of the mucosal tissue. And if this injury is not being treated properly, it will get infected. Bacteria can get into the marrow area and it can start the inflammation and can lead to the formation of osteomyelitis. Orofacial infection, any infection in the orofacial area has a potential to form osteomyelitis if not treated properly. Right. You may have what we call hematogenous spread from distant infection. For example, you have a tuberculosis osteomyelitis where you have a spread of Mycobacterium tuberculosis, which has spread from other area to the jaw area, right? And as I mentioned before, compound fracture of the jaw also can cause osteomyelitis to the jawbone. Right, now let's look at the predisposing factor to osteomyelitis. You can divide into local factors and also systemic factors. Local factors basically reduce the vascularity or blood supply in that particular area. So when you have decrease in vascularity, you have that will affect the vitality of the bone. Systemic factor, on the other hand, will impact the host defense mechanism, meaning the immune system will be affected. right? So these two factors can predispose the patient to osteomyelitis. So what are the local factors? Local factors, you may have trauma to the area. For example, like I mentioned before, any injury to the jawbone, any maxillofacial injury which involve the maxillary area can lead to potential osteomyelitis formation. Radiation injury, patient who has undergone radiation may also been predisposed to osteomyelitis. Paget disease, where you have bone density. Bone density has changed, where you have a denser bone, you will have a potential for osteomyelitis formation, osteoporosis, and also major vessel disease. Major vessel disease basically due to the formation of atherosclerosis. So when you have thickening of the cholesterol plaque in the blood vessels, that can reduce the blood supply to the area. Looking at the systemic factor, anything that can cause, that can affect the immune system can impair the host defense mechanism. Patient who is immunosuppression, for example, patient who is on chemotherapy. Patient on chemotherapy has a immune depression. So that can also predispose the patient to osteomyelitis. Diabetic mellitus, diabetic patient, poorly controlled diabetic patient has a high potential for osteomyelitis. And patient who is malnutrition and the elderly are more predisposed to osteomyelitis compared to the younger patient. Right? So these are the local factors and the systemic factors that you should know. So what is the general pathogenesis of osteomyelitis? How does this happen? Remember that osteomyelitis is inflammation, inflammatory process of the entire bone, which started from the cancellous area and then spread to the cortex and collected underneath the periosteum, or the pus can be drained either through the intraoral opening or extraoral opening. Right. Okay, so I have mentioned about the local factor and the systemic condition. So this is the general pathogenesis, how osteomyelitis occurs. So if we look in detail how this thing happen in the jawbone. So if you have an odontogenic infection, for example, a grossly carious 3-7, grossly carious 3-7 with a periapical pathology. So you will have infection from the periapical area into the surrounding bone. So there will be inoculation of bacteria into the bone marrow. So when the bacteria has invaded the area, it will induce acute inflammation. Right. So when the body will start releasing all these inflammatory mediators, right? So that will lead to pus formation. Right. So when you have pus formation, and you have a tissue necrosis, this pus formation will be accumulated in the marrow space. So that will increase the intramedullary pressure. So when you have increased intramedullary pressure, this will compress the surrounding structure, including the blood vessel. So you will have what we call vascular collapse. You will also have what we call vascular thrombosis. So this will reduce the blood supply. The blood supply to the surrounding area, and this will lead to the ischemia of the bone. Then you have necrosis of the bone, bone necrosis. Right. So this pus will then travel through the Haversian system, and then it will perforate through the cortical bone, and then it will be collected under the periosteum. Right. Okay. So once it is collected under the periosteum, a continuous irritation to the periosteum will compromise the periosteal blood supply. You know, periosteum is a tissue which is rich with blood supply. So when the periosteum blood supply has been compromised, it will reduce, or the blood supply to the cortical area will be affected, right? So you will have all this infected bone, and you will have what we call avascular infected bone. Avascular meaning the necrotic bone has no blood supply at all. So then this pus will perforate through the periosteum, and then it will either drain intraoral or through the extraoral opening. Right. So later on we will discuss about this cloacae, which is a gap between the cortical bone, which allow the pus to drain from the marrow to the extra or intraoral opening. So this is the basic pathogenesis of osteomyelitis caused by odontogenic infection. Right. So here you can see this is the bone, this is the bone, the surrounding tissue. You have, this is what we call sequestrum. Sequestrum is the necrotic bone, right? You have the sequestrum, dead bone or necrotic bone, which is surrounded by involucrum. Involucrum is new layer of bone which is formed on the existing bone, right? And then you have this pus accumulation. Pus will be accumulated in the marrow space. Then it will perforated through the cortex, and it will be collected underneath the periosteum. So the periosteum get expanded, and then at the weakest area it get perforated, right? So this fistula is what we call cloacae. The cloacae is actually the gap or the space between two cortical area which allow the pus to drain from the marrow to the surrounding area. So here it can either go in, it can either drain into the intraoral cavity or it can drain through the extraoral cavity, right? So here is the, if you look at the CT scan, you can see the affected bone with cloacae. Okay, there is the cloacae and the sequestrum. So pus will be drained from here. This will go through the cortex, and they will go to the periosteum, through the skin, and then extraorally, right? So this diagram is very important for you to remember. Remember the sequestrum, which is the necrotic bone, the involucrum, the new layer of bone, which is covering the existing bone. That is how the body defends itself. And then don't forget the cloacae, right, where the pus can be drained out from the medullary space to the surrounding area. Right. So if you look inside the mouth, you can see here on the left side of the mandible exposed necrotic bone with opening which allow the pus to drain out. And here you can see on the OPG on the left side, the affected bony area, you can see a lot of sequestrum and with cloacae here, right? And then this part will be very weak. So it can lead to what we call pathological fracture. Right. Here you can see how bad is the bony destruction around the tooth area. So when you raise the flap, if you expose the affected bony area, you can see there is no bone in this particular region. So the tooth can be very mobile, and the tooth can be very mobile, and sometimes the mental nerve will get compressed, and then you will have what we call altered sensation or paresthesia. Okay, here you can see the opening in the oral cavity. So the pus will drain into the oral cavity. Right. Here another view. Remember, this is not a healthy bone. A dark yellowish colored bone is a necrotic bone. This is what we call avascular necrotic bone. There is no blood supply to the bone. Right. This is another view of osteomyelitis. You don't see bone at all. Okay. So if you take an X-ray at the earliest stage of osteomyelitis, basically at the earliest stage you don't see much, because at the earliest stage you will only see slight decrease in density of the involved bone. So the trabecula will appear fuzzy. So usually after 4 or 6 weeks and above, you will see the radiographic changes clearer, right? Okay, so this basically I've mentioned about sequestrum just now, right? And then radiographically, you will see what we call moth-eaten appearance. Moth-eaten appearance, because this is basically reflecting the changes in the bony trabecular area. So you will see irregular and ill-defined bony margin, and radiographically it will appear as moth-eaten appearance. Okay. Right. There are 3 types of osteomyelitis that you should know. One is what we call suppurative osteomyelitis. Second, non-suppurative or sclerosing osteomyelitis. And the third one is specific osteomyelitis. This is granulomatous osteomyelitis, right? Suppurative osteomyelitis, there are three types: acute suppurative osteomyelitis, chronic suppurative osteomyelitis, and infantile osteomyelitis, which basically affect young children. All right. So suppurative meaning this type of osteomyelitis produce pus. So you may have acute or chronic suppurative osteomyelitis. Okay, the second type, this is non-suppurative. It doesn't produce pus, but it increases the bony density. So that is what we call sclerosing. So when you take X-ray, you will see an radio-opaque appearance around the area. Right? Why? Why radio-opaque? Because increased density of the bony area due to the pathological changes. Right. Here for non-suppurative sclerosing osteomyelitis, you may have chronic focal sclerosing osteomyelitis, or what we call condensing osteitis. Then you may have chronic diffuse. One is focal, the other one is diffuse. And then you may also have what we call Gare osteomyelitis, right? So remember these three: chronic focal sclerosing osteomyelitis, chronic diffuse sclerosing osteomyelitis, and Gare osteomyelitis. The third type, this is very quite uncommon, is what we call specific or granulomatous osteomyelitis. There are three types. You may have tuberculous osteomyelitis, which is caused by Mycobacterium tuberculosis. You may have spilitic osteomyelitis and actinomycotic osteomyelitis. Right. If you look at the clinical features or radiographic features, they look alike. The specific osteomyelitis look more or less like the acute or chronic suppurative osteomyelitis. The only difference is the different type of bacteria, which you can collect from the affected area, right? Because for specific osteomyelitis, the bacteria is very specific. Okay, right. So what is the sign and symptom of acute osteomyelitis? Right, for acute osteomyelitis, because there are a lot of inflammation, and so you may have pain, you may have trismus, at a later stage you may have purulent discharge, you may have fever and malaise, there will be change and disturbance in sensation, especially for the mandible, the involvement of the mental nerve. And in a severe case, you may have tooth loosening, you may have enlargement of the lymph node, and you may have also intraoral or extraoral fistula formation. So is this acute osteomyelitis not being treated accordingly, it will lead to the formation of what we call chronic osteomyelitis. So chronic osteomyelitis usually develop after 30 days. It can go 30 days to 4 months. So in this situation, yes, the jaw will still feel pain, and then there will be swelling, there will be a lot of suppuration. Okay, it's less severe than acute. So the pain is less severe than acute osteomyelitis. For chronic osteomyelitis, there is a very high chances for pathological fracture, and there will be large fistula formation. Okay, now let's look at the microbiology. Remember, I mentioned the difference between specific osteomyelitis and the acute and chronic suppurative osteomyelitis is the type of bacteria that can be collected. Right. So for granulomatous or specific osteomyelitis, there are three types of bacteria: Mycobacterium tuberculosis, actinomyces, and Treponema pallidum. Right. For the acute suppurative and chronic suppurative osteomyelitis, the most common bacteria involved is the Staph aureus, Staphylococcus aureus. The rest are Streptococcus, Bacteroid, Klebsiella, Fusobacterium, Lactobacillus, and Haemophilus bacteria. So you have to remember the different type of bacteria. So we're talking about a specific bacteria, only three bacteria in concern: Mycobacterium tuberculosis, Actinomyces, and Treponema. For acute and chronic osteomyelitis, the most common bacteria involved is Staph aureus, and the rest are Streptococcus, Bacteroid, and Klebsiella. So what are the investigations that need to be done? Right. Of course, clinical history is very important, because you need to get a proper clinical history, because this will lead you to what type of investigation you're going to conduct. Right. Okay. The most important thing is culture and sensitivity. If you suspect osteomyelitis, you need to do culture and sensitivity, either past CNS or blood CNS. Right? Routine blood investigation is very important. You need to get a clear blood picture of the whole of the patient, and then biopsy. If you take biopsy, it will be advisable to take bone marrow biopsy. Why bone marrow? Because sometimes these bacteria, they can hide their self from the effect of antibiotic. Why and how? By hiding in the necrotic bone, or it can hide in the surrounding normal cell. So that is why sometimes you need to take a piece of bone marrow for a better culture and sensitivity. And diagnostic imaging also very important. You can either take a plain X-ray, intraoral. You can take PA or PA or occlusal X-ray. You can also take OPG, and then you can also send for CT scan or combined CT scan, CBCT. Right? So these are the mode of investigation: CNS, blood investigation, biopsy, bone CNS, and then diagnostic imaging. Right. So if you look at the conventional diagnostic imaging, this is plain X-ray. If you look at the PA of this tooth, you can see pathological changes at the periapical and periapical area and the lateral aspect of the root of the first molar tooth. Here is the OPG, also very important. You can see changes at the mandibular area. Right. CT scan will give a clearer picture. It's good to give, a three-dimensional view of the pathology. Right. Here is what we call combined CT scan, CBCT. Now almost every hospital has this CBCT. So here you can see a good view of the affected mandibular region. You can see what we call moth-eaten appearance. This is what we call moth-eaten appearance. Okay, so you can have axial, coronal, or sagittal view of the pathology. Right. Okay, this is a view of the CT scan. You can see the axial view. You can see the pathology at the mandibular region. Here you can see this part almost pathologically fractured. Here you can see the sequestrum. And the sequestrum would appear very radio opaque. Right? Why? Because it is surrounded by the involucrum, the new bone. Okay, then you can see the periosteal bony reaction. All right. Okay. Here you can see the pathology. This is the moth-eaten appearance. All right. Again, here moth-eaten appearance. So CT scan is very good. It gives a 3D view and also a view from the axial, coronal, and sagittal dimension. Right. So if you look at the radiographic features, the earliest radiographic changes occurs after 4 to 14 days. So the earliest changes occurs after 4 to 14 days. So within 2 weeks, you will see the changes. So you don't see at the earliest stage. Only after the fourth or 14 days, you will start seeing the changes. Right. So for osteomyelitis, you will have what we call radio-opaque and radiolucent appearance. Because why radio-opaque and radiolucent appearance? Because you have area of necrotic bone, and then you have area of new bone formation, involucrum, sequestrum. So all this will give you the mixture of radio-opaque and radiolucent appearance. And the appearance of the trabecular and the damaged cortical bone will give this moth-eaten or cotton wool appearance. Okay. As I mentioned before, the sequestrum will appear very dense. So it will be more radio-opaque compared to the normal bone. Right. So for subperiosteal bone formation, this is basically how the periosteum responding to irritation to the area. So it will start laying down a layer of bone. So you will see what we call orange peel appearance or fingerprint appearance on the X-ray. All right. The cloacae can be seen as a dark shadow passing through opacity. Here, if you look, this is what we call the cloacae. There's the gap between two cortex. So you have the marrow, the squamosome, which is separated from the surrounding bone. You have the involucrum, surrounding, forming layer on the existing bone, and also surrounding the sequestrum, and also the glaucae. Yeah, right. Again, there is the sequestrum. Look, it is very radio opaque, very dense, and then you have the involucrum, the new bone surrounding the area, and also the sequestrum. Right. Again, here you can see on the CT scan a clear view of the sequestrum, the moth-eaten appearance, the glaucae, right? And all this has a potential for pathological fracture. In Gary osteomyelitis, you will have what we call onion peeling, or orange skin appearance. You can see layer and layer of periosteal bone formation. If you cut an onion, you can see layer of onion. So same thing here, you will see layer of new bone. This is what we call periosteal bone. See, this is the normal cortex. Okay, you have the periosteum, and then you have layer of new periosteal bone, right? Okay. So for focal sclerosing osteomyelitis, you will have increased radio density at the apical area, with intact or widening of the periodontal ligament space. Okay. Histopathologically, in acute osteomyelitis, you will find a lot of inflammatory cells. There will be vascular changes. You will see vascular congestion and thrombosis. You will see tissue changes. You will have edema and inflammatory exudate. And also for acute osteomyelitis, you will at this acute stage, you will see minimal evidence of bone death. You will see more during the chronic stage. Right? So this is the histopathological features of the acute osteomyelitis. Right? For chronic osteomyelitis, you see more of the bony changes. So you see necrotic bone, the sequestrum. You will see involucrum. You see bone loss at certain area. So that will contribute to the radiolucency of the area. And then you will see inflammatory cell, which is predominantly lymphocyte and macrophages. All right. And then you will see fibrosis formation. The bone marrow will be replaced by fibrosis tissue. And of course, you will see formation of sinus tract. Right here, this is what we call correct histopathological view of chronic suppurative osteomyelitis. Okay. Right. For sclerosing osteomyelitis, what you will see histopathologically, there will be chronic inflammation. Basically, lymphocyte and plasma cell will be predominantly in the area. There will be a lot of fibrosis. There will be bone remodeling, sclerosis. There will be sclerotic activity, increased sclerotic activity. You will see irregular bone and trabeculae. Okay, and then you will also see sequestra. Okay, sequestra you don't see in sclerosing osteomyelitis because in sclerosing osteomyelitis you don't have suppurative. So you don't have pus formation, so there will be no sequestra. Right, so that is the difference between sclerosing osteomyelitis and suppurative osteomyelitis. Right, so this is sclerosing or condensing osteomyelitis. Right, so there are a lot of pathological changes that you need to know when you're talking about differential diagnosis, because almost sometimes it will look alike. Like condensing osteomyelitis will look like a cementoblastoma. Condensing osteomyelitis will look similar to cementoblastoma. All right. So there are many different bony pathological condition that you must know before you can come to a differential diagnosis. So these are the differential diagnoses that you should know. Hypercementosis, cementoblastoma, cementoosseous dysplasia, odontoma, osteoblastoma, osteoma, and osteoid-osteoma. So remember this very well because this may come up in your exam. Right. So what is the general treatment for osteomyelitis? First, eliminate the source of the infection. That is the first thing to be done. Eliminate the source of infection. And then you may or you may not need to give antibiotic to the patient. Sometimes surgery is indicated, either very simple or moderate or very radical surgical approach. So this may involve decortication, resection, and reconstruction of the surgical area. And then as an adjunct treatment, you may also need to refer patient for hyperbaric oxygen. We will talk about this later. All right. So treatment basically for surgery, either conservative or radical. Conservative, simple one like you are removing the necrotic bone, what we call debridement. Radical, where you resect the affected area and then you reconstruct the area with titanium reconstruction plate, or you can use autogenous bone. All right, antibiotic. When talking about antibiotic, even in the antibiotic era, chronic osteomyelitis remain difficult to treat and still has a high rate of relapse. Why? Because of bacteria evasion of the host defense. How bacteria avoid this host defense activity? Either by hiding in the host cell, they can invade and hide inside the host cell. They can also create a biofilm that forms a physical barrier which prevents the bacteria from penetrating into the area and kills them, right? And they also can hide themselves in the sequestrum, in the necrotic bone. So, in the acute or chronic suppurative osteomyelitis, there will be abscess formation. So, in the abscess, you may have sequestrum. So, bacteria can hide themselves in the sequestrum, and then this sequestrum will be surrounded by involucrum, right? And then, so this sequestrum act like a space for the bacteria to survive and multiply. So that is why antibiotic is very difficult to penetrate through the sequestrum. And that is the reason why for osteomyelitic patient, you need to give antibiotic for a very long period of time. And that is why also you need to take a bone marrow culture and sensitivity. Because if you take from the surrounding bony area, you may not be able to get the bacteria. But if you can get the bone marrow, that is where you can get the bacteria, especially in the sequestrum. Okay? Right. So usually long-term antibiotics is indicated about 4 to 8 weeks of duration. So antibiotics basically determined by culture and sensitivity. That is the best way to determine what antibiotic to be given to patient. So this is either you take a swab or blood culture. Okay, swab or blood culture, or you can take sample of tissue. Sample of tissue meaning you do marrow culture and sensitivity. Okay, right. So what antibiotic need to be given is you have to give parenteral antibiotic. Right, so commonly given penicillin, metronidazole, and also cephalosporin. Sometimes in the very chronic cases, you need to give antibiotic impregnated bead. This is the antibiotic bead, where which has been impregnated with antibiotic. So this long bead can be inserted into the area which has been debrided, and then it will stay there, and then it will deliver high concentration of antibiotic. The most common one that has been used is gentamicin or tetramycin bead. Talking about surgery, the simplest one, surgical procedure that can be done is IND, incisional and drainage. You incise the area, allow the pus to drain, and then you take a pus swab. Or you can remove the source of the infection. Either you remove the tooth or you do root canal treatment to the tooth. Okay, you can do sequestrectomy. This is where you remove the necrotic bone in order to improve the blood circulation into the area. You can also do saucerization. This is where you remove the adjacent bony cortex, allow for open packing, and permit for secondary healing. Okay, decortication is where you remove the infected cortex, and then you cover the area with then you cover the exposed bone marrow area with periosteum. Remember, periosteum has a good blood supply, so when you cover the area, it will allow healing into the area. All right. So for a very severe case, you may need to resect the jaw and then you need to reconstruct, because if you resect and you don't construct, the jaw cannot move together. So there's no continuity of the jaw. So you can either put a long titanium reconstruction plate, or you can put autogenous bone graft, for example, a fibula graft, which is secured by titanium plate. Okay, so that is how we do surgery. Right, here, if you look at the X-ray, you can see the necrotic bony area. Okay, and when you open up the area, you can see dark yellowish bony area, which is necrotic bone. So you can debride, you can remove this, you can debride the area and allow circulation. All right, here where you do saucerization, you open up the area, you remove the overlying bone, and then you curettage or debride the area. Okay, same thing here. You remove the cortex and debride the area. Okay, this is circumflexectomy. After you remove the area, you will debride. You remove using a special instrument. You debride the area until the bone start to bleed. Because when the bone start to bleed, meaning you are hitting a normal bone. A necrotic bone doesn't bleed. So when you scrape the area and then you can see it start to bleed, meaning you are hitting you are hitting a normal bone. So that will be your boundary. Okay, right. This is decortication. If you look at this diagram, this is where you remove the infected cortex. You remove the infected cortex, and then the exposed bone marrow is covered with the periosteum. All right. This is where a very bad case at the left mandibular region. So what you need to do, you resect the area. You resect the area, then you reconstruct, either using a thick reconstruction plate, or you can put a fibula graft in between. So this fibula graft will gap the two bony edges, and then it will be secured by a reconstruction plate. Right, this is how we do the surgery. All right. So simple conservative surgery will involve a systemic antibiotic, morphines, and simple surgery, removal of small sequestra, or you can do curating and local debridement. So this is what we call conservative management. Radical involve sequestrectomy, bony resection, and you may need to send patient for hyperbaric oxygen. Right. Okay. Okay, so after 4 to 6 weeks or 4 to 8 weeks of treatment with antibiotics, with all the surgical procedures, and there is no improvement or no response, you need to consider sending patient for adjunctive hyperbaric oxygen therapy. So hyperbaric oxygen improve the penetration of antibiotics, and it stimulate new bone formation. It stimulate osteogenesis. So the infected bone, which has a decreased oxygen content, once you expose the patient to hyperbaric therapy, hyperbaric oxygen therapy, the blood circulation will improve, and that will allow a good bony healing. Okay, the immune response also will be restored, the function of the leukocyte will be restored, and then with the increased immune activity, the infection will be reduced. And then the penetration of the antibiotic also will be improved by hyperbaric oxygen therapy. So this is hyperbaric oxygen chamber. Okay, this is what we call hyperbaric oxygen chamber. But not every hospital has this facility. Why? Because this is quite expensive. All right. So in hyperbaric oxygen chamber, the patient will be placed in the chamber, and the oxygen will be given by mask or hood. And then this hyperbaric oxygen therapy consists of breathing of 100% oxygen at a 2.4 atmospheric pressure for 90-minute session. And each session is called dive, right? So the treatment will be given for 5 days per week for at least 30 to 100 dive for a duration of 90 minutes. Okay, so when you do hyperbaric oxygen therapy, it will increase the arterial and venous oxygen tension. It will increase the immune response by improve the bacteriostatic effect and the phagocytosis. It will induce new blood vessel formation, increase fibroblastic proliferation and collagen synthesis. And of course, with all this, it will enhance the new bone formation. So that is the beauty about hyperbaric oxygen therapy. Right. So the last 15 minutes, we'll talk about the type of osteomyelitis. Okay, remember you have suppurative, acute, or chronic suppurative osteomyelitis. So for suppurative osteomyelitis, the source basically come from infection of the surrounding area, basically from odontogenic infection. You can also get from orofacial infection, from trauma. Okay, the most common bacteria involved is Staphylococcus. Right. So again, the mandible is more prone than the maxilla because of the density and the type of blood supply to the area. All right. Okay, this we have mentioned just now, how the pathogenesis of osteomyelitis take place, where you have infection at the periapical area, the bacteria will invade the marrow space, induce inflammation, and then you will have dead tissue formation, pus formation, increased intramedulla pressure, which can lead to vascular collapse, vascular thrombosis, and then the increased intramedullary pressure will push the pus through the halvation system, and then it will be accumulated underneath the periosteum, and then fistula will form either intraoral or extraoral, and the pus will be drained out from the affected area, and then you have all this squastrum or necrotic bone formation. Right? Okay, again, you have seen this. Okay, right? So basically, in acute suppurative osteomyelitis, the radiographic features, as I mentioned, you don't see during the first 4 days. You will start seeing after the 4th to 14 days. Right? So here you can see early stage of squastrum formation. Right? So management for acute suppurative osteomyelitis, CNS, of course, very important. Sometimes you need to do drainage. You need to get analgesic because patient will be in pain. So antibiotic is determined by culture and sensitivity. And then before you give antibiotic, you may need to do some local debridement. And also you may need to remove the source of infection, either extraction or you can do root canal treatment. For adjunctive treatment, this is where you need to do sequestrectomy. Decortication usually reserved for chronic cases, hyperbaric oxygen, and then resection and reconstruction for extensive bone destruction, right? Only for extensive bone destruction, all right? So what happens if you don't properly treat acute osteomyelitis? So there will be pathological fracture, it will transform into chronic osteomyelitis, it can lead to cellulitis, and the worst thing, it can lead to septicemia. So for chronic suppurative osteomyelitis, which is as a result of inadequate treatment of acute osteomyelitis, okay, this will result in the formation of squastrum and then granulation tissue, scar formation to wall off the infected area. Okay, that is how the body responded to chronic infection. All right, so there will be squastrum, which will act as a reservoir for bacteria, right? So that is why antibiotic need to be given for a long period of time, and that is why bone marrow biopsy or culture and sensitivity is indicated for chronic suppurative osteomyelitis, right? This is a classic view of chronic suppurative osteomyelitis. See, you don't see this in acute cases, right? Acute cases usually very focal, very localized. Where for chronic, you see extensive destruction of the bone, right? Here as well, okay, and here as well. Right, so this is the radiological view. You see the defect here. You can see involucrum formation around the bony area, squastrum with involucrum surrounding it, and then a small cloaca here. Okay. So again, management for chronic suppurative osteomyelitis usually is difficult to manage medically, meaning medication won't basically resolve the area. So surgical intervention is mandatory because the defect is so big, so you need to do surgical intervention. Either you do squastrum, decortication, or resection. All right. So small lesion, you can do curettage, simple debridement, curettage. Extensive osteomyelitis, you can do decortication. For a very severe one, you can resect and remove, and then you can reconstruct the area. All right. Okay, then sclerosing osteomyelitis. We have spoken about the suppurative. Now, sclerosing osteomyelitis. This is a chronic non-suppurative inflammatory bone disease. Non-suppurative. So you don't see squastrium in sclerosing osteomyelitis. This is often characterized by recurrent pain and swelling in the mandible. It can be focal or it can be diffuse. Again, mandible is more common than maxilla. All right. So no pus or fistula. So there is absence of fistula, absence of abscess, or there's no squastrium can be found in sclerosing osteomyelitis. Radiographic features, you see a lot of sclerotic activity. There will be periosseal reaction. You have subperiosteal bone formation, which will give onion peel appearance or onion skin appearance. If you take occlusal X-rays or OPG, you will see this onion skin appearance. Okay, there will be loss of normal structure. There is meaning there is loss of the usual clear distinction between the cortex and the medullary bone, and sometimes the mandibular canal become obscured. It can become obscured. It can get obstructed, right? So when it get obscured or obstructed, it will compress against the inferior alveolar vessels and also the neurovascular bundle. So you may have altered sensation. You may have reduced blood supply to the area. So histological features for sclerotic bony lesion, you will see the bone shows increased density. There is no significant cellular abnormalities or dysplastic bone remodeling. There will be inflammatory infiltrate. For diagnosis of sclerotic bone, basically clinical evaluation, and then it's based on radiographic evaluation and your differential diagnosis. So treatment, of course, you need to eliminate the potential source of the infection. Surgical intervention is usually indicated, even though for some cases, when you remove the potential source of the infection, the thing will resolve. But sometimes for those cases which have ended up with bony deformity, obvious bony deformity, you may need to go in for surgical intervention. Antibiotic may or may not be needed. Right. So for focal sclerosing osteomyelitis, also known as condensing osteomyelitis, this is localized area of bony sclerosis. So it's a bony reaction. How the body respond to a low-grade periapical infection. Okay. So it is associated with what you call low-grade periapical infection. So clinical features for focal sclerosing osteomyelitis is very common in children and young adults. In mandible, you see more common in the posterior aspect, meaning premolar and molar region. The bone sclerosis is associated with non-vital or pulpitic tooth. And usually there is no expansion of the jaw because the pathology is within the bone. So it doesn't cause any bone expansion. So histological view, you will see this dense sclerotic bone, scanty connective tissue, and a lot of inflammatory cells. So this is how focal osteitis looks like. You look here, you have radio opacity at the periapical area. Again, radio opacity with intact or widening of the periodontal ligament. Same here. Okay. Okay, so you may have widened and intact periodontal ligament. Okay. So management, basically, first you remove the source of infection, potential source of infection, meaning either you do extraction or you do a root canal treatment. Okay, and usually after the removal of the lesion, what you call source of infection, this pathological area will undergo resolution, and so that bony resolution is known as bone scar. Bone scar or bone fibrosis. Right. For diffuse sclerosing osteomyelitis, this is an ill-defined, highly controversial evolving area of the pathological area. So for focal sclerosing osteomyelitis, the border or the margin is very well defined. For diffuse, sometimes it can be very ill defined. You don't know where to stop. You don't know where the lesion actually stop, right? So you look at this diffuse sclerosing osteomyelitis. Basically, we don't know where the pathology end. Same here, you don't know where the pathology end. So if you do a radical treatment, for example, you need to resect quite a lot of bone. So that is the difference between diffuse and focal. Focal, you will see the lesion at a localized area. Diffuse, this is how it looks like. It's diffuse around the mandibular area with no definite pathological margin. Right? So clinical features, usually minimum pain, minimum or no pain. Usually there will be no swelling, again because it's diffuse within the bone. Right? Okay, histologically, you see bone sclerosis and remodeling and scanty marrow spaces, and you will see secondary bacterial colonization. Okay, and radiographic features, usually it will show as cotton wool appearance, and the radio opacity can be very extensive and it can be bilateral. Okay, so since it is very diffuse in nature, it's very difficult to differentiate between the normal and the pathological area. So the margin will be very difficult to differentiate. Right, treatment. Okay, basically the treatment will focus on removal of the source of infection. Okay, but if the lesion is too extensive, it may need to be treated surgically. All right, and also you need to give antibiotics. Okay, so remove the source infection. If the lesion is too extensive, you may need to go for a surgical intervention, and then you may need to give antibiotics. Right. Okay. For Gare osteomyelitis, or also known as proliferative parostitis, okay, this is a rare chronic inflammatory lesion which is commonly affecting children and young adults. Okay, it's characterized by localized thickening of the periosteum of the cortical bony area. So you have irritation of the periosteum at that affected area. So this irritation, the periosteal irritation, will will allow the body to start laying down layers of cortical bone. So because of this layering of cortical bone, you will have what we call this onion skin appearance, right? So for Gare osteomyelitis, it can cause mandibular enlargement. So it will cause bone deformity. So you will see on the buccal aspect of the mandible, there will be bony enlargement. Right? So so when that happens, there will be facial deformity. There's either obvious or mild or moderate facial deformity. So basically, Gare osteomyelitis is due to low-grade odontogenic infection. And again, mandible is more commonly affected than maxilla. Okay. So this is how it looks like. If you take an occlusal X-ray, so this is the normal cortex, you will have onion skin appearance. Okay, layer of periosteal bone formation. Okay, this is how the Gare osteomyelitis looks like radiographically. Okay, right. So this lamination varies from 1 to 12 in number. So it depends. So the higher the number, the greater the bone deformity will result. Okay. So if you look at if you cut an onion, you will see this lamination. So basically the same. So that is what we call onion peel appearance. Sorry. Okay. So radiographically, see, if you take occlusal view, you can see this lamination of bone. This is the cortex, normal cortex, and then this is the affected cortex, which has result in chronic irritation of the periosteum, and then you start having all this periosteal bone formation. All right, here again you can see on the occlusal X-ray the onion skin appearance. Okay. So treatment for Gare osteomyelitis, removal of offending cause. If the bony swelling is very minimum, usually we leave it because the body will be responding. It will remodel because the overlying muscle will help the area to remodel. But if the deformity is very severe, you may need to go for surgical intervention. Okay, the last slide is on granulomatous osteomyelitis. Look at tuberculous osteomyelitis of the jaw. It's a very rare bone infection which is caused by Mycobacterium tuberculosis. Mycobacterium tuberculosis bacillus that affect the mandible. So this is what we call hematogenous spread. So it spread from one area to another area via the blood circulation. So the symptom like swelling, may have pain and loosening of the teeth. Okay, and you may also have subperiosteal abscess formation. Okay, so treatment usually patient will need to go for a long course of anti-tubercular therapy, meaning they will be on anti-TB therapy. All right, surgical intervention sometimes may be needed if the if the bony deformity is very severe. Okay, or the bony necrosis or the bony damage is very severe, you may need to go for surgical intervention. Surgical intervention, as I mentioned before, may involve local debridement, squastectomy, decortication, or resection of the affected bone. Right. So, okay, that's the conclusion of my lecture. This is my reference. And then, okay, that's it for the lecture today. Okay, guys. So the slide has been uploaded, so you can refer to my slide. If you have any question, you can post it in the WhatsApp, and I can answer it for you. All right. So I'll be seeing you again next week, same time. But honestly, I've forgotten about the lecture title for next week. But never mind. We seeing again next week. So have a nice day. And for my Indian student, I wish you a happy Deepawali. Hope you have a great festive season. Okay, so thank you very much. Have a nice day and study hard. Thank you. Bye.
Thank you, Doctor.
Thank you, Doctor.
Thank you, doctor.
Thank you, Doctor.